Welcome back to Weekly Neurology Deep Dive. As always, this is purely for educational purposes, no commercial angles here. We're diving into a key paper. But remember, this is just a highlight reel. We always encourage you to read the full paper afterward to get the complete picture. This week, we're looking at something that could be a real game changer for us neurologists, gene editing therapy for ATTR-CM.
Yeah, it's a significant development,
Yeah.
especially when you consider the limitations of our current treatment options for this challenging condition.
Exactly. Right now we're talking about lifelong medication regimens for ATTR-CM, a progressive disease that only gets worse over time. But this new research published in the New England Journal of Medicine on December 12, 2024, presents a potential alternative, a single-dose gene editing therapy. The paper is titled CRISPR-Cas9 Gene Editing with Nexigerin for ATTR Cardiomyopathy.
Wow, using CRISPR-Cas9 technology to target the root cause of the disease.
Yeah.
Nexigerin, or Nexa as they call it, targets the gene encoding transthyretin, the protein responsible for those amyloid buildups we see in ATTR-CM.
And a single intravenous infusion, that's what really caught my eye. Imagine addressing the root cause with one treatment instead of daily or weekly medications.
It's a potential paradigm shift in how we manage ATTR-CM. I mean, the implications for our patients are huge.
Absolutely.
Yeah.
So let's dive into the study itself. It was a phase 1 open-label trial involving 36 patients with ATTR-CM. It's worth noting that these weren't all mild cases. About half of the patients were in NYHA Class 3, indicating moderate to severe heart failure.
And that's a key point for neurologists. We need to know how this therapy performs in patients who are already experiencing significant cardiac involvement. Also worth mentioning that 31% of the participants had the variant form of ATTR-CM, which, as you know, can be even more challenging to treat.
Right. So we're seeing a mix of disease severities and types, giving us a better sense of Nexa's potential across a broader spectrum of patients. Now let's get to the results. What was the impact on TTR levels?
The results were frankly remarkable. They saw a mean reduction in serum TTR levels of 89% at just 28 days after a single infusion. And what's even more impressive is that this reduction was sustained holding steady at 90%, even at the 12-month mark.
Those are impressive numbers. A 90% reduction in TTR is sustained over a year from a single dose that's unheard of with our current treatment options.
And it's important to highlight that this dramatic reduction was consistent across all patients. It didn't matter what their baseline TTR level was, the dose of Nexi they received, or their specific genotype. This consistency is really encouraging.
It certainly suggests that Nexi could be effective for a wide range of patients with ATTR-CM. But what about safety? That's always a top concern, especially when we're talking about gene editing.
Of course, safety is paramount. In this study, the most frequent adverse events were related to cardiac failure, which isn't surprising given that many participants already had this condition.
So we're talking about pre-existing issues, not necessarily side effects of the therapy itself.
Exactly. We need to be careful not to conflate the two. It's important to look at what the researchers identified as treatment-related adverse events.
And what did they find?
5 patients experienced transient infusion-related reactions. These were generally mild or moderate and resolved quickly. Then there were 2 cases of temporary liver enzyme elevations, which were considered treatment-related. These elevations resolved within days without any specific intervention.
And what about those 14 patients who experienced serious adverse events? That number initially seems concerning.
It does, but it's essential to dig deeper. Only one of those serious adverse events, an infusion-related reaction, was attributed to Nexi. The others were primarily related to the pre-existing ATTR-CM. Sadly, there was 1 death from ischemic heart disease, but the researchers determined this was unrelated to the treatment.
So the overall safety profile seems promising so far, but obviously long-term monitoring is crucial. Now, I know this was a phase 1 trial primarily focused on safety and TTR reduction, but did they look at any secondary endpoints?
They did, and the findings regarding disease stability are particularly interesting. NT-proBNP, a key marker of heart failure, showed a geometric mean factor change of 1.02 at 12 months.
So essentially, NT-proBNP levels stabilized instead of continuing to rise as we'd expect with disease progression. That's a positive sign.
It is. And they saw a similar pattern of stability with high-sensitivity cardiac troponin T, another important biomarker. The geometric mean factor change for this marker was 0.95 at 12 months.
Both of these findings suggest that Nexi could be doing more than just reducing TTR levels. It might actually be halting the progression of the disease, and that's after just 1 dose.
What about functional capacity? Did they look at the 6-minute walk test?
They did. The median change from baseline to 12 months was a slight increase of 5 meters.
Now, I know 5 meters might not sound like much, but remember, this is a progressive disease. In ATTR-CM, even maintaining function is a win, and in this case, we're seeing a slight improvement. Precisely. And when you look at the NYHA class changes, the picture gets even brighter. 47% of the patients improved by at least one class, while 44% remained stable. Considering progressive nature of ATTR-CM, this is a remarkable finding.
It's a testament to the potential of this therapy to not just stabilize the disease, but actually improve patients' functional status.
And the post-hoc analyses add another layer of intrigue. They found that 66% of the patients showed no worsening across any of the prognostic markers at the 12-month mark. No worsening in NT-proBNP troponin levels or 6-minute walk distance.
That's really striking. It suggests a broad-based benefit across multiple measures of disease activity. And this wasn't limited to patients with milder disease.
Right. This stability was observed in 83% of patients with NYHA class I or II, and importantly, in 47% of those with more severe disease, NYHA class III.
So even in patients with more advanced ATTR-CM, we're seeing a potential for stabilization.
It really challenges our understanding of what's possible with ATTR-CM treatment. Of course, we need to be cautious. This is a small, single-center trial without a control group.
You're right. It's important to keep that in mind. Larger, longer-term studies are needed to confirm these findings and truly assess the long-term efficacy and safety of Nexa.
Absolutely. But even with those caveats, the findings are incredibly encouraging.
They certainly are. This potential for a single-dose treatment to not just manage but potentially halt or even reverse ATTR-CM progression is a paradigm shift.
I agree. And it highlights the incredible potential of gene editing as a therapeutic tool, not just for ATTR-CM, but for a range of neurological conditions.
It's an exciting time to be in neurology, that's for sure. But let's not get ahead of ourselves. We still need to see data from the ongoing Phase 3 MAGNITUDE trial, which is going to be crucial for getting those definitive answers about the long-term impact of Nexa.
That trial will be key. It's going to involve a larger and more diverse group of patients and will track them over a longer period, allowing us to get a much clearer picture of the long-term efficacy and safety profile.
And importantly, the MAGNITUDE trial will look at key clinical outcomes like hospitalization rates and overall survival, which weren't the primary focus of this initial Phase 1 study.
Exactly. Those clinical outcomes are what ultimately matter most to us and our patients.
So we have this groundbreaking Phase 1 data, and we're eagerly awaiting the results of the Phase 3 MAGNITUDE trial. In the meantime, what else should neurologists be considering as we digest this information?
I think it's crucial to delve into the details of the study population. Understanding the characteristics of the patients who participated in the trial can help us better interpret the results and assess the potential applicability of Nexa in our own practice.
That's a good point. The paper provides a lot of detail about the patient demographics and baseline characteristics. For instance, the median age was 78 years, ranging from 46 to 90. And notably, 97% of the participants were male.
That skewed gender distribution reflects the real-world demographics of ATTR-CM. As you know, the condition tends to affect men more often than women.
It does raise questions about the potential efficacy and safety of Nexa in women with ATTR-CM. Hopefully, the MAGNITUDE trial will enroll a more balanced cohort of patients to provide more insight into this aspect.
Agreed. In terms of disease severity, the paper tells us the median NT-proBNP level at baseline was 2052 nanograms per liter, a significant elevation, indicating substantial cardiac involvement in these patients.
That's important to keep in mind when interpreting the results. The fact that they saw such impressive TTR reductions and signals of disease stability in a population with established cardiac involvement is even more encouraging.
Another point to note is that the patients in this trial weren't on any TTR stabilizer therapy at baseline. This was due to limited availability in the UK at the time of the study.
So the effects we're seeing are likely due to Nexa alone, not influenced by other disease-modifying therapies.
Exactly. That makes the results even more compelling. Now let's talk about the treatment itself. In the dose-finding portion of the study, Nexa was administered at either 0.7 milligrams per kilogram of body weight or 1 milligram per kilogram.
And what about the expansion phase of the study?
For that, they used a fixed dose of 55 milligrams, equivalent to 0.7 milligrams per kilogram. This dose was selected based on the safety and efficacy data from the earlier dose-finding phase.
So they identified a dose that seemed to strike a good balance between efficacy and safety. What can you tell us about the infusion process itself?
The infusion was designed to be relatively straightforward, aiming for a minimum infusion time of 2 hours. To manage the risk of infusion-related reactions, patients received a pre-treatment regimen.
What did that regimen consist of?
It involved dexamethasone, a glucocorticoid, a histamine H1 receptor antagonist, and a histamine H2 receptor antagonist. This pre-medication strategy was implemented to minimize any potential adverse reactions to the infusion.
Smart. And speaking of infusion-related reactions, the paper mentions that 5 patients experienced these. 4 of them were mild or moderate in severity.
Yes, suggesting that these reactions were generally manageable and not a major safety concern.
But there was one case of a severe reaction.
Right. That particular reaction occurred in a patient with more advanced disease, specifically NYHA class 3 heart failure. This patient developed hypotension, requiring overnight observation in the hospital. Fortunately, they responded well to treatment with intravenous saline, and the reaction resolved quickly.
It seems like even the more severe reaction was effectively managed with standard supportive care. Now, the paper also delves into the potential impact of Nex-Z on vitamin A and thyroid hormone levels. What's the connection there?
Well, TTR, the protein targeted by Nex-Z, is involved in the transport of both vitamin A and thyroid hormone in the body. So it was essential to investigate whether disrupting TTR production might have any downstream effects on these hormones.
And what did they find?
As you might expect, vitamin A levels did decrease after treatment with Nex-Z and remained low throughout the follow-up period. However, they didn't observe any clinically relevant changes in thyrotropin levels, which is a key indicator of thyroid function.
So while Nex-Z did affect vitamin A levels, it didn't seem to have a negative impact on thyroid function.
Exactly. And importantly, there were no clinical signs or symptoms of vitamin A deficiency or thyroid hormone abnormalities in any of the patients.
That's reassuring. It suggests that while monitoring these parameters is important, the impact of Nex-Z on vitamin A and thyroid hormone levels doesn't appear to be a major clinical concern.
I agree. Now, shifting gears to the secondary endpoints, the paper presents a wealth of data on changes in various biomarkers and functional measures. These secondary endpoints give us clues about how Nex-Z might be affecting the disease course beyond just TTR reduction.
Let's start with NT-proBNP. We already touched on the stabilization of this marker at the 12-month mark.
Yes. The geometric mean factor change of 1.02 suggests that this important heart failure marker remained relatively stable rather than continuing to increase as one would expect in untreated ATTR-CM.
And we saw a similar pattern of stability with high-sensitivity cardiac troponin T. The geometric mean factor change for that marker was 0.95 at 12 months.
Together, these biomarker results reinforce the idea that Nex-Z may be halting the progression of ATTR-CM.
And then there's the 6-minute walk test, which measures functional capacity. The median change in the 6-minute walk distance was a modest increase of 5 meters. Again, not a dramatic improvement, but in a progressive condition like ATTR-CM, even maintaining functional capacity is a positive sign.
Precisely. And when you look at the changes in NYHA class, the findings are quite remarkable.
You're referring to the fact that 47% of the patients actually experienced an improvement in NYHA class, meaning their heart failure symptoms improved. That's nearly half the patients showing a clinically meaningful improvement in their heart failure severity after just a single dose of this gene therapy.
It's an impressive finding, and it shouldn't be overlooked. And when you consider that another 44% of the patients remain stable in their NYHA class, it suggests that Nex-Z might be halting the progression of the disease in a significant proportion of patients.
The post-hoc analyses add yet another layer of insight into the potential benefits of Nex-Z. They found that 66% of the patients showed no worsening across any of the key prognostic markers, NT-proBNP, troponin levels, or 6-minute walk distance at the 12-month follow-up.
And remember, this stability wasn't confined to patients with milder disease. They observed this positive trend in 83% of patients with NYHA class I or II, and remarkably, in 47% of those with more severe disease in NYHA class 3.
That's a very important point. It suggests that even those with more advanced disease may experience some degree of stabilization. These findings are genuinely exciting. But as we discussed earlier, it's crucial to acknowledge the limitations of this study. It was a small single-center trial without a control group.
Yeah, it does make it a little hard to say for sure that all these improvements are from the Nex-Z. I mean, some of what we're seeing could be the disease just doing its thing or some other factor we haven't accounted for.
Plus, we've only got a year of data here.
Right.
So we don't really know what the long game looks like for Nex-Z. More data will help us understand if this reduction in TTR holds up over time. What the safety profile looks like long term. and how it all affects the progression of the disease down the road.
That's where the phase 3 magnitude trial comes in.
Exactly.
It's designed to address all that.
Yeah.
We need that long-term data, to really see how Nexi works in a bigger and more diverse group, what it means for outcomes like survival and hospitalization.
Looking forward to seeing those results.
Yeah.
But even with these limitations, I think it's fair to say that the phase 1 trial findings are pretty remarkable.
They are. To see a reduction in TTR that big that lasts, along with these early signs of the disease stabilizing and maybe even getting better, is truly encouraging.
Speaking of those encouraging signs, I thought the paper's detailed breakdown of the adverse events was helpful. It's always important to really weigh the risks and benefits, especially with something as new as gene editing.
I agree. Transparency around safety data is so important. I think the authors did a really good job of giving us a full picture of the adverse events they saw.
Like we said before, the most common adverse events were mostly those tied to the patient's underlying ATTR-CM,
Right.
cardiac failure,
Right.
upper respiratory tract infections,
Right.
atrial fibrillation, urinary tract infections.
Right. And this shows how important it is to choose the right patients and monitor them carefully, especially in trials like this with folks who already have other health issues. We need to be able to tell which problems are from the therapy and which are just part of the disease itself.
When we zero in on those treatment-related adverse events, two stand out: infusion-related reactions and those bumps in AST levels.
Yeah, 5 patients had those infusion-related reactions. And as we said, most were mild or moderate, resolved pretty quickly with just supportive care. And there were 2 cases of those temporary spikes in AST,
Right.
a liver enzyme.
And those were considered treatment-related and resolved in about 10 days without needing any special intervention. It's reassuring that those liver enzyme elevations were temporary and cleared up on their own.
Definitely. Seems like they didn't do any lasting harm.
And like you mentioned before, out of those 14 patients who had serious adverse events, only 1 was thought to be directly because of Nexi.
Right, that one infusion reaction. And it's important to highlight that most of those serious adverse events were what you'd expect to see with ATTR-CM anyway.
Exactly. This does highlight the need for continued monitoring, but it doesn't necessarily raise any major concerns about the safety of Nexi itself.
I agree.
Now, I know we talked about the primary endpoint of TTR reduction already, but I think it's worth mentioning again just how impressive those results were. I mean, an average of 89% reduction in serum TTR at just 28 days. And it stayed at 90% reduction even at 12 months. That is pretty amazing.
It is, especially since they did that with just 1 dose. It really shows the potential of gene editing to, fundamentally change the course of this disease.
And see those results across the board in all the patients, no matter their baseline TTR, the Nexi dose, or their genotype, that adds another level of wow factor.
That consistency is a big takeaway here. It suggests Nexi could be a good option for a lot of different people with ATTR-CM.
And the paper digs into how they think this big drop in TTR is happening. It seems like the Nexi with its CRISPR-Cas9 action is essentially switching off the gene that makes TTR.
Right.
It's that targeted disruption that's causing the big and lasting decrease in the TTR protein in the blood.
Yeah.
And that seems to be what's giving us those good signs we're seeing in terms of how the disease is progressing.
Exactly.
With the NT-proBNP and troponin T leveling out and those 6-minute walk distances holding steady, it suggests that Nexi might be doing more than just lowering TTR levels. It could be actually changing the underlying disease process itself.
Of course, we need more data to confirm that. We need to know how long these effects last and whether Nexi can really change the long-term trajectory of ATTR-CM.
And that's where that phase 3 magnitude trial comes in. It's going to give us the information we need about how long that TTR reduction lasts, the safety over time, and the effects on those really important things like hospitalization and survival. It'll also help us see where Nexi fits in with all the other treatments we have for ATTR-CM. How does it compare? Who's it going to work best for? The magnitude trial should hopefully answer a lot of these questions.
I hope so, too.
This has been a fascinating look at this new potential treatment for ATTR-CM.
It has.
We've seen some very convincing evidence that it can lower TTR, signs that it might be stabilizing the disease, and even some hints that it could make things better clinically. While we wait for the results of the phase 3 magnitude trial, it's safe to say that this research is a major leap forward.
It is. It's a real testament to the power of scientific discovery and a reason to be cautiously optimistic as we keep looking for better treatments for our patients.
Thanks for joining us in this deep dive into the world of gene editing and ATTR-CM. If you want a closer look at this research, be sure to check out the full article in the New England Journal of Medicine and listen to that audio editorial that goes with it. Until next time, keep diving deep.